Hello, everyone. Today we'll be talking about low back pain. The presentation is divided into two parts, part one and part two. Today will be part one, and then hopefully next week will be part two. Objectives of this presentation is um, give you a review of the anatomy, and particularly the posterior compartment. So this week I'll be talking about the posterior compartment of the lower back, and next week it will be, inshallah, the anterior compartment. Also, we'll be talking about the prevalence of low back pain, causes of low back pain, how to diagnose sacroiliac and facet pain, since these are the posterior compartment structures, differential diagnosis, lumbar spine algorithm, and we'll end with some key learning points. So this is the posterior compartment. We're talking about ligamentum flavum. We're talking about interspinous ligaments. We're talking about facet capsule. We're talking about spinous process, supraspinous ligaments. This is what we're talking about today. And sacroiliac joint as well. Okay, we'll show you a picture later. Okay, so what is the prevalence of low back pain? Statistics indicated that at least 5% of the population in the United States suffer from low back pain each year. And it's one of the main sources of sick leaves and doctor visits all over the world. Common causes of low back pain: muscle sprain or strain, herniated nucleus pulposus, annular fissure, zygophyseal joint arthropathy, spondylolisthesis, ankylosing spondylitis. All of these are the routine causes of low back pain. But we have what we call the red flags. These are the emergency causes of low back pain. These are the ones that need, patients to go to the ER, okay? Such as discitis, osteomyelitis, epidural abscess, metastatic cancer, for example. And then there's another distinction here between mechanical low back pain and non-mechanical. This is very important as far as management, guys. Okay? So non-mechanical include neoplasia, include inflammation, include infection. All of these are under the umbrella of non-mechanical. Now, we'll jump into the sacroiliac anatomy, which is going to be an important part of this presentation. Sacroiliac joint is a highly ligamentous joint because it's a weight-bearing joint. So it has to be ligamentous, so it can tolerate this body weight, and transmit it basically to the lower extremities. Uh, Sacroiliac ligaments has 6 types of ligaments. Okay, you need to know them as a pain physician, such as the ventral sacroiliac ligament, sacrospinous sacrotuberous, interosseous dorsal sacroiliac ligament, and the iliolumbar ligament. And particularly, the iliolumbar ligament plays a very important role in a groin pain. Groin pain could be related to iliolumbar ligament laxity. Okay? Sacroiliac innervation, controversial, but generally speaking, the dorsal aspect, which is the part that we have access to, okay, under X-ray, is from the dorsal root ganglion of L4 to S3, and basically, the lateral branches, uh, and then from the ventral aspect from L1 to S2. Causes of sacroiliac pain could be after lumbar fusion, could be related to a trauma, pregnancy. Patients that have hypermobility syndromes like Ehlers-Danlos or Marfan syndrome, and then seronegative spondyloarthropathies, such as ankylosing spondylitis or psoriasis, for example. Prevalence of sacroiliac pain is around 10 to 38%. Okay, so this is an important issue here. And then the pain pattern of sacroiliac pain could actually refer to buttocks in 94%, lower lumbar region 72%, lower extremity in 50%, and groin, remember the iliolumbar ligament, in 14%. Diagnosis of International Society of Pain. Pain in the sacroiliac joint region by palpation. Okay, remember these three P's, guys. We're gonna use them in every aspect here in pain management. Then pain reproduced by clinical testing. Okay, stressing the joint. This is called provocation, another P. And then injecting local anesthetic in the joint or the nerve that's going to the joint, and this is called palliation. So three P's for the diagnosis here. Sacroiliac joint pattern pain, as you see, buttocks, the back of the thigh and back of the, leg here, and the groin. Provocative tests. We have 5 tests: compression, distraction, Faber. This is the most important one: flexion, abduction, external rotation, Gainslin, and thigh thrust. You have to have 3 at least of these 5 positive when you do your provocative test here. By palpation, you can do this 14. This is the name of a guy here, name of a doctor. 14 finger test, where you just stick a finger at the sacroiliac joint. So what is the difference between sacroiliitis and sacroiliac dysfunction? Sacroiliac dysfunction means that there is a ligamentous problem. Okay, not necessarily there's an inflammation, but sacroiliitis is basically an inflammation. Could be related to an inflammatory rheumatic process like negative spondyloarthropathies, or could be acute sprain of the sacroiliac, like trauma or sprain of the ligament, can lead to some inflammation. It's very important to uh, differentiate, because with SI dysfunction, you don't need to inject steroids, but with sacroiliitis, you need to give anti-inflammatory medications or injecting steroids in the area of the sacroiliac joint. Seronegative spondyloarthropathy. You can actually you have a mnemonic for it: pair, psoriatic, enteropathic, ankylosing spondylitis, and then reactive arthritis. Psoriatic arthritis manifested by spondylitis, arthritis mutilans, enthesitis, dactylitis, distal psoriatic arthritis. 30% of psoriatic patients have, by the way, psoriatic arthritis. And around 80% of patients with psoriatic arthritis have psoriasis. Enteropathic arthritis due to inflammatory bowel disease like Crohn's and ulcerative colitis. It gives another presentation of pyoderma gangrenosum, oral ulcers, erythema nodosum, and symptomatic uveitis. Okay, ankylosing spondylitis occurs more in men less than 45 years old, and characterized by restricted motion all over the spine with an inflammatory process, and gives a picture of what we call bamboo sign in the X-ray. And there's a restricted motion that you can detect by a famous test called modified Schober test. All right, ankylosing spondylitis shows up early on in the sacroiliac joint. Reactive arthritis is a rather rare problem. In these patients, they develop conjunctivitis, they develop arthritis, and they have also urethritis as well. And they have this mnemonic: cannot pee, cannot climb a tree, and cannot see. All right. We'll jump into another condition here called benign joint hypermobility. By the way, this is a very common problem. At least 5% of the population has this condition. It shows up mainly in adolescence, okay? And it can lead to different pain complaints in different parts of our body. You cannot say that this is a disease. This is more or less like a normal variant of, just joint issues here. How you detect it? You do something called Beaton score. If you score more than 5 out of 9, you have hypermobility syndrome. Now, the problem is once you diagnose hypermobility, you have to do your differential, okay? And the differential could be something like Ehlers-Danlos, okay, or which is discovered by these two dermatologists here, or it could be something else. Now, these are the Ehlers-Danlos is a very complex disease, and there are at least 13 subtypes, okay, of Ehlers-Danlos syndrome, and it's characterized by skin hyperextensibility, joint hypermobility, recurrent dislocations, organ rupture, increased tendency to bleed, and as I said, there are at least 13 different types of Ehlers-Danlos syndrome. Okay, another condition called Marfan syndrome, and this is characterized by lens dislocation, the eyes, aortic dilatation, mitral regurg. As you see, their fingers are very tall. We call this arachnodactyly, and they have a positive wrist sign and thumb sign. It's an autosomal dominant disease discovered by this guy, Antoine Marfan. He's a French pediatrician. Okay, so this is it is basically chromosome 15 is the one responsible for this disease, and it's a disorder of the fibrillin 1. By the way, I remember I picked up some of these Marfan syndromes. These guys can live for a long time without being diagnosed. Okay, I just want to tell you, I had a couple of these cases in my practice where I discovered them by accident. Okay, but anyway, I just want to let you know because not all the cases will be well diagnosed before it comes to you. Okay, differential diagnosis of sacroiliac, you have the most important one is the lumbar facet arthropathy here, lumbosacral radiculopathy at L5S1 radiculopathy, superior cluneal nerve entrapment. Okay, we see this, more and more nowadays. Patients usually complain about with pain above the iliac crest here. Iliopsoas muscle spasm or quadratus muscle spasm could cause a similar pain to, a sacroiliac pain. Piriformis, gluteus medius, and then sacral fracture. We call this the Dennis classification. When you have a trauma, you can have a, fracture in either of these zones here, zone 1 or zone 2 or zone 3. Of course, as you see, zone 2 is the most, scary one because it goes through the sacral foraminae. Okay, and this is a kind of a wrap up to all the diagnosis and differential diagnosis of sacroiliac pain. Okay, how we deal with it? We have an algorithm for the lumbar spine. I'm going to talk about it more extensively next week. But basically, it's a 3-step algorithm. First step, conservative. Second step, spinal injections. Okay. And third step is surgical interventions. Conservative, like, doing good education, physical therapy, heel lift or sacroiliac belt, kinesiotaping or acupuncture. Sacroiliac program, I invented this program. Okay. It's composed of 5 Ds. First, to test for true leg discrepancy, uh, Don technique exercises, dextrose injections, Don joy, sacroiliac belt, and deactivation of trigger points. Don technique exercises, these are specific for sacroiliac pain. Please go into the website lowbackpain.com. I do this all the time. The purpose of this program is to bring the sacroiliac back in its normal place. Because sacroiliac has a small movement. We call it notation, counter notation. And if it goes too far, it can sprain the ligaments. Okay, also checking whether this is a true leg discrepancy or not, or false. False is related to the notation, counter notation of the sacroiliac. But true leg discrepancy, you have to put a shoe lift or a heel lift. Okay, we see this all the time, guys. All right. Unfortunately, most of the people, they don't give they don't really check on these things, and the problem is the patient, gets the injection, feels better, and then the patient will keep coming back again because of the same problem, because you didn't solve the root of the problem. Okay, dextrose injection, this is what we call prototherapy. After you do your Don technique exercises or manipulation, you do the dextrose to strengthen the ligaments. Here in this picture, the injecting the iliolumbar ligament. This program of prototherapy was developed by George Hackett, a Cleveland Clinic surgeon in the 50s. Okay, another important part is the belt. Don't joy sacroiliac belt. Kinesiotaping is another way to do it. This was developed by Kenzo Casey, this guy here, and he came out with this beautiful, cotton and latex-free tape. Um, uh, you know, uh, I have some at home, and it really helps a lot with pain. When you put it, you have to do a little bit of stretch, and you have to read a little bit about how to utilize it. It's not a big deal. You can do it yourself. It's not, but yeah, the location of the taping and everything, is important. Okay, periosteal stimulation. I've done a lot of these in my life where I just stick a needle in the PSIS, and you don't have to do anything else, and just peck on it, a few times until the patient feels the pain. And trust me, it's just magic. So this is a substitute of doing a sacroiliac joint injection. Spinal injections are these, like sacroiliac or facet regenerative injection therapies. You can inject phenol, you can do radio frequency ablation or cryoneurolysis. Okay, so SI injection could be done interarticular or periarticular. The interarticular is done mainly in elderly folks. Okay, these guys, they have a true osteoarthritis, all right, and it's usually bilateral. But the periarticular is usually done for, patients that are young and had trauma, and usually the pain is unilateral. You can make easily the distinction. Sometimes it's difficult, but most of the time you can make the distinction. Interarticular versus extraarticular. Okay, you can use a landmark technique, or you can use ultrasound, or you can do it under fluoroscopy. Also, there's been some research where they injected phenol. Phenol is a neurolytic agent. They injected phenol interarticular. Okay, regenerative injection therapies. We can be done with dextrose, 15%. We talked about it, and or we can use a platelet-rich plasma. In these situations, we're trying to strengthen the ligaments of the back. All right, now if the injections does not help, we need to escalate our therapy to do radio frequency. Okay, any type of radio frequency has to be done after you have done your diagnostic block with local anesthetic. So the first type is pulsed radio frequency, and this one is traumatic because you use low temperature, below 42 degrees, and basically it magnetizes the nerves that's going to the sacroiliac. Then we have another two types, water-cooled radio frequency and conventional radio frequency. These are like cousins, but this one, it gives a bigger lesion. So it's useful, but the drawback, the needles are big also, so you have to really give enough sedation while you're doing this water-cooled radio frequency. All right, as you see, the lesions are done here at the lateral branches of, from L5, dorsal ramus, and lateral branches from S1 to S3. Another company came out with something called Simplicity. They invented the probe where you can stick it and you do the burning, just one lesion, burning all these lateral branches, at one shot here. Cryoneurolysis is a new invention, okay, where you kind of freeze the nerves. We used to do it in old days, but we used to have very large probes, so it wasn't really interesting to most physicians here. Nowadays, they're using very tiny probes, as you see here. Okay. Now, when you do cryoablation, it doesn't hurt. Okay. And in fact, you can check it out with an ultrasound. It shows you, an ice ball with ultrasound. So this is a big plus. I can see the lesion itself. Okay, this is the Sunderland. So this is the nerve anatomy, myelin sheath, endoneurium, perineurium, fascicles, and blood vessels here. And then you have, wrapping up the whole nerve is what we call epineurium. Okay, Sunder classification is important for nerve lesions. Now, reversible nerve lesions are first degree and second degree. Non-reversible starts from third to fifth. Okay, so pulse radio frequency, it doesn't go beyond this first to second degree here. So it's not really traumatic. However, conventional RF, you go up to fifth degree. So the nerve is basically severed completely with a conventional or water-cooled radio frequency. With cryoneurolysis, you cannot reach this fifth degree. You reach this third or fourth degree, and then later on, after a few months, you go back to second and first degree, because the nerve regenerate again. So this is the big plus of doing cryoneurolysis. Okay, this is a comparison between conventional pulse and cryoneurolysis. With cryoneurolysis, you really freeze the nerve. You use something called a Joule-Thomson effect, and you use gases called either CO2 or nitrous oxide. All right. Cryoneurolysis versus conventional radiofrequency. Again, cryoneurolysis is more, less harmful and more expensive. Let me put it this way. It takes a little bit more time to do. I'm going to talk about a sacroiliac fusion. This procedure is getting some, interest to pain interventionists in patients that basically, failed everything. I remember I had a patient like this um, from KFMC, and she was doing well on the side where it was fused, but the other side was very painful. Okay, and usually these patients, they can develop what we call trochanteric bursitis here. Okay, we'll jump into the facet. The facet is different innervation than the sacroiliac. They're supplied by the medial branches. Remember, the sacroiliac is supplied by the lateral branches. These are supplied by the medial branches. Now, L5 doesn't have a medial branch. It's a dorsal ramus. Okay, so we inject it as a dorsal ramus. Okay, so again, this is the L5 dorsal ramus. Okay, and these are, each joint gets a nerve supply from a nerve from the same level and one from the nerve below. Okay, this is very important when you do your denervation. So for each joint, you have to burn two nerves. Okay, what are the causes of facet joint disease? Osteoarthritis, especially elderly folks. Like all joints start this wear and tear problems. Maybe also some trauma added to it. Synovial cyst, we see this a lot. Okay, rheumatoid arthritis or ankylosing spondylitis, and sometimes related to segmental instability. Okay, from ligamentous laxity or trauma. The facet pain is around 15% in young adults and 45% in older patients. Again, how you pick up a facet pain? By palpation, 3 P's: palpation, provocation, what we call the quadrant test, and palliation. When you do your facet, just go with your thumb next to the spinous process here. These are the facet area here. And then you do the quadrant test, and then you do the injection under X-ray. You will have a diagnosis of facet pain. As you see, it has a pain pattern somewhat similar to sacroiliac pain. Okay, this is the quadrant test. Provocation of the facet is done, joints are done through extension and lateral rotation. Okay, you can inject either the joint or you can inject, the nerve, the medial branch. Okay, this is under X-ray. This is the Scotty dog, appearance of, of the facet joint. This is the medial branch is at the eye of the Scotty dog, and the ear of the Scotty dog is the facet joint itself. Okay, we'll talk a little bit about myofascial pain and trigger points. This was really the founder of myofascial pain. Her name is Janet Travell. She was the, JFK private doctor. Anyway, so as you can see here, for example, quadratus lumborum, muscle spasm, it can mimic exactly sacroiliac pain and facet pain. It has two parts, superficial and deep. And Janet Travell used to call it the joker of the back, because it causes a lot of symptoms, and it's very commonly seen. Now, how to test for it? By this test, by trying to move the leg in extension with the fibers of the quadratus lumborum. If you get tightness there, then you have a problem with your quadratus muscle. Of course, you palpate it. Remember the law of 3 P's that I put for you: P for palpation, P for provocation, and P for palliation. So palliation is basically injecting the muscle. Then you have piriformis muscle syndrome, is extremely common problem, and it can give you pain in the buttock area going down to the leg. And the test for piriformis is called the FAIR test: flexion, adduction, and internal rotation. Remember the FABER for sacroiliac, flexion, abduction, external rotation. This one is FAIR. They love to ask this question in the board exam. All right. The piriformis is a muscle in your buttock that goes around the sciatic nerve, above the sciatic nerve. But unfortunately, sometimes the sciatic nerve split inside the muscle, or go one part above and one part below. This is called the Beeson and Anson classification. Okay, you can inject the piriformis at its insertion or in the middle. The problem with this one is, you have to be careful because the sciatic nerve just lies behind this area here. All right, quadratus lumborum and psoas major muscles also can be done under fluoroscopy or ultrasound. Quadratus here, psoas here. You have to be very, you have to know these muscles very good because they go into the differential. And most of the failed injections, guys, are related to these, under recognizing these muscle syndromes. Okay, how do you identify psoas spasm by a test called a Thomas test? As you see, when you flex your normal leg, in this situation, the other leg keeps relaxed. But if you have a contracture in the psoas, this leg will be elevated. Okay, gluteus medius is another muscle. Okay, that can give you similar picture to iliopsoas here. To iliopsoas, to sacroiliac. So it's part of the differential diagnosis of sacroiliac pain. Okay, I want to talk a little bit about this one because it's important. The lumbar, supraspinous, and interspinous ligaments. So we have a condition called spondylolisthesis, where one vertebrae is basically slipped over the other. And of course, it's great. There's grade 1, 2, 3, and 4. The grade 1 and 2 could be treated with some injections in the ligaments in the spine, like the supraspinous, interspinous, the facet joint. You can strengthen these ligaments with dextrose or prolotherapy. Okay, if there is radicular manifestations and it's pushing in a nerve, you can inject steroid injection here. All right. So not all the cases of spondylolisthesis needs surgical attention. Some of them you can treat with injection, especially the early cases, the stage 1 and stage 2. You can inject, do a comprehensive regenerative injection therapy program. Okay, and you can inject all these ligaments, and this could help quite a bit, keeping the patient going without, getting a spinal fusion or lumbar fusion. All right, so what are the key learning points? Chronic low back pain is multifactorial in its generators of pain. A thorough history and physical, coupled with properly selected diagnostic imaging, physical therapy, and pharmacological management, successful interventional treatment algorithm. When we talked about the lumbar spine algorithm, which is basically 3-step, a method to deal with chronic low back pain. All right, I think I'm done here. Thank you so much. I think we have like 3 minutes here.